Hello everyone, this is your podcast for thought disorders. The thought disorders include schizophrenia as the exemplar and several other related disorders. Schizophrenia is a common and serious neurobiologic illness that affects 1% of people globally and approximately 2.5 million Americans. Schizophrenia is thought to be a combination of disordered thinking, perceptual disturbances, behavioral abnormalities, affective disruptions, and impaired social competency. You can see from the slide it talks about the definition of schizophrenia. A disconnected mind involves a lack of coherence in mental functioning. Thinking, feeling, perceiving, behaving, and experiencing operate without the normal linkages that make mental life comprehensible and effective. Here are some famous people, or well-known people, diagnosed with schizophrenia. Got Mary Todd Lincoln, John Nash, Peter Green, Alan Alda's mother, he was the Hawkeye on MASH, Jack Kerouac, Albert Einstein's son. Some hallmarks of thought disorders. To think about these thought disorders, they are serious and often persistent. These mental illnesses are characterized by disturbances in reality, orientation, thinking, and social involvement. The hallmarks that you can see on the slide: disturbed thinking, preoccupation with frightening inner experiences, those delusions and hallucinations, marked disturbances in affect. Generally it's flat, inappropriate. Behavior is unpredictable and bizarre. And social interactions, oftentimes this is a person really in isolation, if you will. They're isolated from other human beings because of that lack of perception of reality. Schizophrenia is the most persistent thought disorder. Now, some of the other thought disorders that are under this category, if you will: the schizotypal personality disorder, delusional disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder. And if you remember, schizoaffective disorder was discussed somewhat in bipolar as well. It was traditionally classified with bipolar because of the associated mania and depression. However, the prognosis for schizoaffective is better than for other schizophrenic disorders, but worse for depression or bipolar disorders. The next one on your slide, or the other one I should talk about, the schizophreniform disorder. 1/3 of the patients recover within 6 months from this disorder. 2/3 go on to develop schizophrenia or schizoaffective disorder. Others are substance or medication-induced psychotic disorder due to another medical condition, catatonia associated with another medical condition, and catatonic disorder due to another medical condition. And you can see that this is the latest from DSM-5. Under DSM-4, oftentimes schizoaffective disorder was classified again with the bipolar disorders. There are 5 subtypes of schizophrenia, and on the subsequent slides we'll talk about those subtypes. On this slide, disorganized. Disorganized speech, disorganized behavior, flat or inappropriate affect. The criteria here is not meant for catatonic type of schizophrenia. So you can see on the slide, disorganized. It's a chronic variety with flat or inappropriate affect. Silliness and incongruous giggling is common. Behavior is bizarre. Social interaction is impaired. The next type we'll talk about on this slide is paranoid. Paranoid schizophrenics, they are preoccupied with one or more delusions or frequent auditory hallucinations. As a matter of fact, voices in schizophrenia are the most common hallucination. You can see that paranoid is characterized by paranoid delusions. They tend to be argumentative, hostile, and aggressive. They are difficult to deal with at best, and we'll talk more about that. Another type is undifferentiated. In undifferentiated schizophrenia, the characteristics are present for 1 month, but the criteria is not met for paranoid, disorganized, or catatonic schizophrenia. These folks have bizarre behavior that does not meet the criteria outlined for other types. Delusions and hallucinations are prominent. Residual, these are folks that have less positive symptoms. We'll talk about those in a little bit. They have an absence of prominent delusions, hallucinations, disorganization. They, however, have continuing evidence of disturbance as indicated by the presence of negative symptoms, or 2 or more of these characteristic symptoms. As you can see from the slide, it's used to diagnose a person who has a history of at least 1 episode of schizophrenia with prominent psychotic symptoms. They are still ill. They have these negative symptoms, or at least 2 characteristics like delusions, hallucinations, disorganized speech or behavior. Catatonic schizophrenia, characterized by 2 things: either catatonic stupor, in which there is extreme psychomotor retardation, mutism. Posturing is common. I'll talk about posturing in just a minute. Catatonic excitement, extreme psychomotor agitation, purposeless movements. Oftentimes with your patients with catatonic excitement, and if they have severe psychomotor agitation and purposeless movements, they must be curtailed to prevent injury to self or others. These folks are characterized by little reaction to the environment and at times excitement and exhaustion. They have 2 prominent symptoms, which we talked about the first day when we talked about assessment. We talked about echolalia, where they repeat all words or phrases heard, senselessly repeating. Echopraxia, they mimic actions, purposeless movements, not influenced by their surroundings. In posturing, which is a third way to look at movement position, they assume a pose or posture that is bizarre or inappropriate. And you can see that on the slide. There's something called waxy flexibility, and this is where you can actually put their extremities, if you will, put them in some kind of position, and they will not move. So that's called waxy flexibility. They have hyperactive activity without purpose. Many times they are mute, or extreme negativism, where they are apparently lack motivation and resistance to all instructions. They can maintain a rigid posture against attempts to be moved, and they have peculiar behaviors, posturing, grimacing, postures which aren't goal-directed. There's several hypotheses for schizophrenia occurrence. And the dopamine hypothesis of schizophrenia is one of the more popular. And in your book, in the chapter on thought disorders, in your reading, you will see 29.1, Understanding Biologic Foundations, and it talks about this dopamine hypothesis of schizophrenia. Normally, when dopamine is released in the brain, it follows normal neural pathways and connects appropriately to nerve cell receptor sites. Feedback and modulation are balanced, contributing to stable behavior and reality orientation. In schizophrenia, excessive levels of dopamine bombard the receptor sites, overstimulating brain areas that are involved with arousal and motivation. The disruption in normal neuronal communication may contribute to hallucinations, delusions, and other psychotic behavior. They also feel another hypothesis has to do with an insufficiency of norepinephrine at certain central synapses in the brain, an imbalance between dopamine and norepinephrine, abnormal glutamatergic and cholinergic processes, and early brain injury. So just to get you thinking in terms of, so what causes schizophrenia? The etiology. It's thought to have multiple etiologies, Schizophrenia's exact cause is unknown. Increasing evidence points to abnormalities that arise early in life, probably before birth, and disrupt normal brain development. The overwhelming body of scientific evidence points to schizophrenia as a brain disease. Some biologic and psychosocial theories regarding the etiology of schizophrenia include, and you can see these on the slide, biologic. There's either a one-gene hypothesis. This proposes that a single gene causes susceptibility. There's also a poly or a multiple gene hypothesis, which proposes that schizophrenia results from the interaction of many genes, but none of them individually is strong enough to produce schizophrenia. Neurochemical and neuroanatomic changes. Clients with schizophrenia have neurodevelopmental defects in brain circuitry and abnormal brain metabolism. PET scans have indicated relative underactivity of the frontal lobes. Again, the dopamine hypothesis of schizophrenia is mentioned. There is a stress vulnerability model under the psychosocial theories. And under the stress of biologic and psychosocial factors, vulnerable people may be predisposed to break down or to develop schizophrenia. Professional consensus is that schizophrenia is due to a complex interplay of both environmental and biologic factors. There are 3 dimensions of psychopathology in schizophrenia. The first, disorganized. Disorganized speech, perseveration, distractibility, where it's the inability to sustain one's attention or attentiveness, which is rapidly diverted from one topic to another. Their speech is often characterized by clanging in neologisms, echolalia, thought blocking, and this is a phenomenon that occurs in people with psychiatric illnesses, usually schizophrenia, and occurs when a person's speech is suddenly interrupted by silences that may last a few seconds to a minute or longer. For example, a person with schizophrenia might remark that another person has removed their thoughts from their brain. They also have disorganized behaviors, motor or social behaviors. The final component of the disorganization dimension is incongruity or inappropriateness of affect. The psychotic dimension involves 2 classic symptoms that reflect confusion about the loss of boundaries between self and the external world. Delusions are disturbances in thought content, and hallucinations are sensory perceptions with a compelling sense of reality but no actual objective basis. Negative include the 5 A's, if you will. Alogia, which is the alogia of thinking. It's inferred by observing the client's language and speech. And I'll talk a little bit more about these in a minute. Affective blunting or flattening, reduced intensity of emotional expression and response. Avolition is the inability to start, persist in, and carry through any goal-directed activity to its logical conclusion. Anhedonia is the loss of the capacity to experience pleasure subjectively. And lastly, attentional impairment. Symptoms of schizophrenia. Signs and symptoms are so diverse they can cover the entire range of human thought, emotion, and behavior. The symptoms last at least 6 months. They include at least 1 month or 2 of more active phase symptoms such as bizarre delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative behavior. And what I want you to think as we go forward is a couple things, but mainly that positive symptoms that we'll talk about in a little bit are the presence of inappropriate behaviors. The negative symptoms are the absence of appropriate behaviors. Again, think in terms of positive symptoms. When we talk about positive symptoms, they are the presence of inappropriate behaviors. Negative symptoms are the absence of appropriate behaviors. If you get those 2 things straight, it'll help you a lot. As far as hallucinations, there are 6 types. it's, well, if you consider the one, there's two kind of categories under tactile, if you will. So let me give you the types first. Auditory, visual, gustatory, olfactory, and tactile. There's a form of tactile hallucination that's called formication, Formication, and it is an abnormal skin sensation similar to that of insects crawling over or within the skin. It comes from the Latin formicare, which means to creep like an ant, not to be confused with fornication. I know what you all were thinking. Auditory hallucinations may manifest as a running commentary of two voices conversing. There are 4 phases of schizophrenia. The premorbid phase. Person's, not quite right, but there's nothing real major to hang your hat on. The prodromal is characterized by deterioration in functioning. Negative symptoms can appear suddenly or slowly during this phase. Remember the 5 A's that we talked about on the last slide. The active phase, this is where the psychotic symptoms are more prominent, particularly delusions and hallucinations. And the residual phase follows the active phase and is characterized by such symptoms as social isolation, eccentric behavior, poor ADLs, alteration in affect, odd speech, magical thinking. It's an easier phase for the patient and family, if you will, although the patient usually does not recover from the effects of the disease or the effects that the disease has had on his or her life. When schizophrenia is not managed, clients may become totally withdrawn from the environment. Their behavior may regress so much that they no longer perform personal hygiene or ADLs, engage with others, or even notice physical illness or pain. So what do we do about it? Well, you can see on the slide there's several categories of intervention. The antipsychotic medications, which we'll talk about in just a minute, adjunctive pharmacotherapies, and again, the addition of some of those other medications to manage symptoms, other categories of medications. Electroconvulsive therapy has shown some promise. Psychological interventions we'll talk about in a little bit. Family interventions, vocational rehabilitation, and assertive community treatment and case management. Some of the things that these patients will need help with: skills training, vocational training and rehab, housing assistance. So let's talk a little bit about the antipsychotics. Another name for antipsychotics is neuroleptic or neuroleptic type drugs. While antipsychotic drugs are used to manage acute positive psychiatric symptoms, induce remissions, maintain stability, and prevent relapse, they are not without side effects. So how do they work? They block dopamine receptors in the brain, altering the release and turnover of dopamine. We use antipsychotics, and this is speaking about antipsychotics, both the traditionals or typicals and your atypicals or your non-traditionals. Indications of severe thought disorders, acute and chronic confusion that accompanies psychoses, extreme aggression, dementia. And again, more about this in a little bit. Adherence to meds and treatment regimen is a chronic problem for many patients with schizophrenia. We must integrate medication management with psychosocial intervention. Rehab therapy really offers the best chances for positive long-term outcomes. Antipsychotic meds are essential to treat symptoms during both the acute and long-term phases of the illness, but they don't cure schizophrenia. So I alluded to this on this slide, but there are 2 categories of antipsychotic drugs to treat schizophrenia: traditional or typical, non-traditional or atypical. Traditional or typical primarily treat the positive symptoms of schizophrenia, hallucinations and delusions. Side effects include these EPSs, or these extrapyramidal effects, and tardive dyskinesia, and more about these in just a minute. The most serious and potentially fatal side effect is neuroleptic malignant syndrome, or NMS. The traditional or the non-traditional or atypical relieve both the positive and negative symptoms of schizophrenia. They are less likely to cause the distressing extrapyramidal side effects. So your typical antipsychotics, these drugs set up a powerful dopamine blockade to control psychosis, but they also block dopamine receptors in the part of the brain that controls finely coordinated movements. These distressing effects may make the client feel worse than before they started taking the med, and this is one of the biggest reasons for non-adherence of these drugs. So in their blockage of dopamine, they cause something called extrapyramidal motor side effects of the antipsychotic medications. This is table 16.6 in your book, in the psychopharmacology chapter. Acute dystonic reactions, acute dystonia, if you will. These are severe muscle spasms that can be life-threatening if not treated immediately. And there are many types of those. Torticollis, severe twisting of the neck and back. Opisthotonus, which is a severe arching of the back. Oculogyric crisis, severe rolling back of the eyes into the head. There is a client down at the nursing care center down at Arch Street, which actually has this rolling back of the eyes into the head, and maybe some of you will see him, maybe some of you will not. The laryngospasm, spasm of the throat in which breathing and swallowing becomes severely impaired, and emergency tracheotomy may be required, so that's a serious one. And oral facial maxillary spasms, spasms of the face, lips, and tongue, making it very difficult to talk, chew, and eat. There are the dyskinesias. These are abnormal muscle movements, not as severe as spasms. Facial tics and twitches, chewing movements, lip smacking, blinking, aimless movements of the tongue, shoulder shrugging, pedaling movements of the legs, flailing arms. The next one is called tardive dyskinesia, and again, this is all in table 16.6. This is kind of a late onset of any of the dyskinesias. Tardive dyskinesia comes rather late in the game. Usually does not occur until 4 to 6 months after treatment with a neuroleptic. It can become permanent and must be treated at the first symptom. And oftentimes the first symptom is, they call it a vermiform tongue. Verma is the word for worm, V-E-R-M-I, so that's Latin for worm. So it's a worm-like movement of the tongue. The tongue darts in and out. The tongue has some different abnormal movements with it. Oftentimes you'll see the lips smacking and the chewing movements that accompany tardive dyskinesia here. There's Parkinsonism reactions, and remember that when you're blocking dopamine, and you think about your Parkinson's patients that maybe you've seen in the past, they have a lack of the neurotransmitter dopamine and overabundance of acetylcholine. And so when you think about like the pill rolling tremor, the tremors at rest, and some of the other manifestations of Parkinson's, the shuffling gait, the drooling, and so on, these are typically because of this overabundance of acetylcholine. It's kind of like the dopamine keeps the acetylcholine in check. And remember that the dopamine is responsible for these finely coordinated movements. So oftentimes when we see a patient with Parkinson's, we think about Parkinson's as a movement disorder. Now in this case, what we've done is we've blocked the dopamine, and so the muscle movements that we see resemble symptoms of Parkinson's disease. Stiffness and slowness of voluntary movement, mask-like immobility of facial muscles, stoop posture, slow monotonous speech, shuffling gait, immobility, the pill rolling tremors that you might see in their hands and so on. Akathisia, A-K-A-T-H-I-S-I-A. This is nearly continual muscle activity, less intense than dystonias or dyskinesias, intolerance of activity, continuous agitation and restlessness, pacing, constant leg and finger movements. So you can see that these EPS, or these extrapyramidal side effects, are very problematic. They are usually treated, when we see these kind of side effects, we treat them with a reduced dosage, or maybe trying a different drug, or adding a med that decreases or reduces the side effect. I want to tell you that tardive dyskinesia is one of the most serious side effects of long-term use of neuroleptics, often is irreversible and severely disabling. These drugs tend to be lipophilic. They are metabolized by the liver. Lethality is low. The risk of side effects is high, especially with older high-potency agents. Other side effects include, for the typicals, include orthostatic hypotension and anticholinergic effects. They also have endocrine effects like breast enlargement, amenorrhea, galactorrhea, and erectile dysfunction. Photosensitivity, tachycardia, sedation, weight gain, and agranulocytosis, and I'll talk a little bit more about that in a couple seconds with one of the drugs. The most dangerous side effect is the neuroleptic malignant syndrome, or NMS, characterized by an elevated temp, severe extrapyramidal side effects, especially rigidity and dystonia, autonomic dysfunction, hypertension, tachycardia, diaphoresis, and an elevated CPK level. NMS is a potentially fatal emergency and requires immediate attention. It's treated typically with dantrolene, which is a muscle relaxant, and bromocriptine, which is a dopamine agonist. Monitoring for side effects and so on should involve the client and family, and it's so very important to teach these patients or these clients about these particular medications. Here is an example of one. This is an oldie, chlorpromazine, or Thorazine. And I gave you one of these little slides. What's Thorazine used for? It talks about the many faces of Thorazine. And then the little caution there is watch for toxic and adverse reactions due to dose and blood levels, which can consist of EPS, particularly akathisia and dystonia, Parkinsonian symptoms, and tardive dyskinesia. And then at the bottom it says, this is a powerful drug. It can cause drowsiness, blurred vision, hypotension, dizziness, decreased sweating, constipation, dry mouth, and nasal congestion. You want a patient on Thorazine to avoid abrupt withdrawal. It may cause blood dyscrasias or the agranulocytosis, dizziness, and tremors. And here's another example of a drug in this category, haloperidol or Haldol. And so again, these just give you some good pictures to try to relate and identify with so you can remember these drugs better. Atypical antipsychotics, again, relieve both positive and negative symptoms. There's less risk of extrapyramidal side effects with these, but these atypicals have a high or significant risk of obesity, diabetes, and metabolic syndrome with hypertriglyceridemia. I'll try to say that 5 times fast, but you all know what that means. That's high triglycerides in your blood. Researchers are investigating the link between the use of atypicals and abnormal glucose metabolism. There's probably more research to be done and more findings to follow. Here are some examples of the atypical antipsychotics, and I'll just kind of highlight some special things about each of these. Clozapine or Clozaril, that was probably one of the first atypical antipsychotics that came out, and it works good. It has resulted in decreased negative symptoms, increased impulse control, reduced violence to self and others, and improved quality of life. But here's the downside. potentially fatal side effect of a granulocytosis. So in this case, you would need to monitor probably weekly white blood cell counts and monitor for signs and symptoms of a granulocytosis or a low white count, which may include symptoms of sore throat, fever, malaise. It is not used as the first-line treatment due to this danger and other side effects. Risperidone or Risperdal, that was, if you think about second generation here, that's probably a good description. It is first-line treatment for both positive and negative symptoms, has reduced extrapyramidal side effects and tardive dyskinesia. The most common side effect is weight gain, and there can be significant weight gain with this drug. Olanzapine is first-line treatment for both positive and negative symptoms, reduced EPS, or extrapyramidal side effects in TD. The most common side effect is weight gain. Again, it has a lower incidence of these extrapyramidal side effects than risperidone, and the substantial weight gain, though, is troublesome. Quetiapine is a newer atypical, and this one's been approved for use in elders with psychosis. Again, weight gain along with some other troublesome side effects. Ziprasidone to treat positive and negative symptoms and depression. This particular drug is weight neutral. Aripiprazole promises a much lower side effect profile than the other atypicals, so this one's becoming a real popular drug to prescribe. And paliperidone is an extended-release derivative of risperidone, lower side effect profile than the other atypicals. So there's some better drugs, newer drugs coming down the pipeline. These are a couple of examples. A key issue, though, is that regardless of the type of antipsychotic prescribed, nurses and other healthcare providers must be vigilant about careful baseline screening and follow-up monitoring to mitigate the risk of various complications that can develop. Adherence to a drug regimen is often derailed because of side effects, be they mild or severe. Nurses can explain that different meds in the same classification can have varying effects, and that if the client does not tolerate one med, he or she may find one that works better with less side effects and better symptom control. Education is crucial to promoting adherence to the drug regimen and relief of symptoms. I'm going to refer you to, in your book, it's Assessment Tool 16.2, and this is a way to figure out if a person is having some of these dystonias and dyskinesias and so on, because it's called the Abnormal Involuntary Movement Scale, or the AIMS. This scale relies on clinician observation to identify abnormal movements associated with adverse effects from antipsychotic drugs. And so again, I would recommend that you take a look at the Assessment Tool 16.2. It is in your pharmacology chapter. The overall goals of treatment for schizophrenia. Optimal model is the interdisciplinary team, and first and foremost, safety in all settings. Assessment of current functioning, medication management, this stabilization on antipsychotic meds. Client and family education about schizophrenia and its treatment. Family counseling goes under kind of this umbrella. Physical care of the client, a crisis intervention, brief inpatient services oftentimes, and then maybe an assertive community setting for aftercare. Psychosocial support of the client and family is extremely important. These clients are extremely difficult for families to deal with sometimes, and so that family that's trying to take care of a family member with schizophrenia is in need of a lot of support. We need a network of ongoing social support. Let's talk about some of the therapies. Psychological therapies include individual psychotherapy, and this is a long-term therapeutic approach. often difficult due to the client's impairment in interpersonal functioning. Group therapy has some success if occurring over the long-term course of the illness, is less successful in acute short-term settings. Behavioral therapy, the chief drawback here has been the inability to generalize to the community setting after the client has been discharged. So we can kind of get them to doing really well when they're in the inpatient setting, and as soon as they get out in the community, there's just not enough support there, and they are unable to generalize the things that worked in inpatient to the things they have to do in the community setting. Social skills training, the use of role play to teach the client appropriate eye contact, interpersonal skills, voice intonation, posture. This is aimed at improving relationship development. Social has to do with milieu therapy, best if used in conjunction with psychotherapy, and family therapy is aimed at helping family members cope with the long-term effects of the disease process. Nursing assessment, what we're going to assess for, of course, is positive symptoms. And we first look at content of thought. Delusions, are there false personal beliefs? Are we seeing a patient that's demonstrating religiosity, or that excessive demonstration of obsession with religious ideas and behavior? Paranoia, where they have extreme suspiciousness of others. Magical thinking, the idea that if one thinks something, it must be true. Word salad, the groups of words put together in a random fashion. And circumstantiality, which is a delay in reaching the point of communication because of unnecessary and tedious details. Then we assess form of thought. Is there associative looseness? Does the person have a shift of ideas from one unrelated topic to another, and so on? Neologisms are made-up words that have meaning only to the person who invents them. Concrete thinking is a characteristic here, and these are literal interpretations of the environment. Clang association, where the choice of words is governed by sound, often rhyming. Tangentiality, no, I did not say that right. Tangentiality, or going off in tangents, is the inability to get to the point of communication due to the introduction of many new topics. Mutism is the inability to speak, and perseveration is persistent repetition of the same word or idea in response to different questions. Next, in our nursing assessment of positive symptoms, we will look at perception. Is the person having hallucinations? How about illusions? Illusions are misperceptions of real external stimuli. How about sense of self? Are you seeing someone that's just doing echolalia or echopraxia? Identification and imitation, taking on the form of behavior one observes in the other. Depersonalization, a feeling of unreality. Nursing assessment negative symptoms. Here are the 5 A's again. Affect. The feeling, state, or emotional tone tends to be flat or bland. Apathy is shown. They are apathetic. They have a disinterest in the environment. They may show inappropriate affect. Emotions are incongruent with circumstances, and it includes something called emotional ambivalence. They react to things without emotion. Avolition, impairment in ability to initiate goal-directed activity, includes emotional ambivalence. Coexistence of opposite emotions toward the same object, person, or situation also can include deteriorated appearance. They're not motivated to do their ADLs, to get cleaned up, to do anything. Alogia is thought of in terms of poverty of speech. Anhedonia, lack of pleasure in things that were previously enjoyed. And of course, we've talked about this before as well, attentional impairment. When we assess cognitive symptoms are very subtle. And like negative symptoms, they may be difficult to recognize as part of the disorder. Poor executive functioning involves the ability to understand information and to use it to make decisions. Trouble focusing or paying attention is often classified as the negative symptom, attentional impairment. Problems with working memory is the inability to use information immediately after learning it. Cognitive symptoms often make it harder for the person to lead a normal life and earn a living. These cognitive symptoms cause great emotional distress. We also assess psychomotor behavior, and anergia is a common find. Waxy flexibility, passive yielding of all movable parts of the body to any effort made at placing them in certain positions. Posturing, voluntary assumption of inappropriate, bizarre postures. Pacing and rocking. Other issues, impaired interpersonal functioning, or relationship to the external world. They often have impaired social interaction, often characterized by social isolation. So here's a question for you. A nurse is caring for a client with schizophrenia and asks him if he is hungry. He states, "There's a stink box in my boomerang." This is an example of neologisms, or made-up words. Here's another question. Which of the following are considered the positive signs of schizophrenia? If you chose C, you chose wisely. Delusions, hallucinations, disordered thinking. Here's one of those things from the nursing education consultants. Kind of helps you kind of pull together a picture of schizophrenia. Another question. Which of the following is most important in working with Joan, who is delusional? Hopefully you've chosen B. B is the correct response. So let's look at nursing interventions next. So we assess a patient for symptoms. What some of our nursing interventions are based around is we want to keep the patient safe, anchor them in reality, establish a trusting relationship grounded in reality. Employ safety measures by giving the client room to breathe, observe for poor judgment, suicidal or homicidal ideation, or agitation. Agitation may be due to hallucinations or delusions. Be accepting, patient, and optimistic. A model for client activities should be non-competitive. They should work on alleviating anxiety, and they should be planned to increase the client's self-esteem. So, as far as assisting with ADLs, we need sometimes to direct those ADLs. We need to assist with those ADLs to make sure that they're done. And always monitor the client taking meds. They may attempt to cheat or hoard them. Here's some other considerations. And again, I have keep safe because this is worthwhile repeating. Be alert for water intoxication. Water intoxication is seen in some clients who drink excessive amounts of water. The reasons for this behavior are unknown, but possibilities include a response to a delusional belief. Maybe changes in the secretion of the antidiuretic hormone or abnormalities in the hypothalamic region, which regulates thirst and fluid intake. So this excessive water intake can lead to hyponatremia and polyuria, seizures, coma, cerebral edema, and even death can result. Preventing excessive water intake can be a challenge, and some clients are treated with fluid restrictions. These clients often become very creative at finding water, toilet water, water from flowers, and so on, so it really doesn't matter. We want to present reality by pointing out appropriate behavior, employ limit setting for inappropriate behavior. We'll use a technique called grounding, and that's best accomplished with short, frequent contacts. We want to use therapeutic communication techniques, short phrases, specific phrases, clarify often. Use therapeutic, Acknowledge hallucinations, acknowledge feelings, but don't reinforce the hallucinations. This is extremely key. Do not attack or challenge the delusional thinking. Acknowledge feelings. Look for factors which may be causing the hallucinations or delusions and attempt to intervene before they occur, if possible. Here's a little slide about recovery. A concept of healing and transformation, enabling a person with mental illness to live a meaningful life in the community while striving to achieve his or her full potential. And so you can see that this is a little kind of graphic, talks about the importance of all of these key pieces in these patients' recoveries. This is from the Mental Health Association, because what we have to keep in mind is that hospital stays are very short. We have to do as much as we can with really limited resources and send them out into the community, hopefully in a structured community setting that will help them to achieve some degree of wellness. There's been a shift in the paradigm of care of persons with serious mental illness from the traditional model of medical psychiatric treatment toward this concept of recovery. Our desired outcomes of treatment include decreased frequency of hallucinations and delusions, the person's ability to recognize hallucinations or delusional thoughts, more logical and reality-based thought processes, improved ability to concentrate, improved ability to interact with others, appropriate affect and mood. Nurses base the evaluation of the effectiveness on treatment on whether functioning has improved. Achieving this goal requires availability and accessibility of appropriate community groups. And again, these are our desired outcomes. And that's the end of the podcast for thought disorders.